Well, I'd like to welcome you today to this session. Good morning, good afternoon, and good evening from wherever you are around the globe. My name is Mary Adam, and I'm going to be your host today. We have an exciting session with panelists from across the globe and a great range of experience, and we're delighted to have you join us. I'd like to ask, if you're a participant, that I would point you to the live Q&A. Log in and tell us a little about where you're logging in from. I'm seeing participants from Palestine, from Australia, from the Bahamas. So thank you very much for joining us today. As I said, my name is Mary Adam, and you are at the session entitled Reimagining Design: How Human-Centered Design Unlocks Potential in View of the Human Capital Index. And we have a panel of very distinguished speakers from across the globe. Next slide, please. I'd like to introduce them very briefly, and they will tell you more about themselves as they discuss their presentation. Brooke Shelton joins us from the US, where she's a patient experience consultant for a large multi-hospital health system called Banner Health Systems. She has extensive experience with human-centered design. Dr. Angie Jonelson also joins us from the US-Mexico border. She's had 25 years of experience in research, planning, and implementation of community development projects. And she has been working together with me on community work we've been doing here in Kenya for the last 5 years. My name is Mary Adam. I'm a pediatrician and a behavioral scientist. I direct the maternal newborn community health program at Kijabi Hospital in Kenya. Kijabi is a faith-based mission hospital where we are serving as well as being a training center. And I'm particularly interested in studying questions at the front line of healthcare. We're also joined from Nairobi, Kenya by Dr. Lydia Okutoy, who's an OBGYN and head of the Department of Quality Care at the country's largest teaching hospital, National Kenyatta Hospital, a 2,000-bed teaching facility in Kenya. And also from Cora Nally, who joins us from the Bahamas. And so let's continue on, all right? Again, I said, please, if you're joining us, log into the live chat and tell us a little about where you're joining us from. Thank you, and I'm gonna hand it over to Angie as our first presenter. Angie, I'm gonna ask you to unmute and begin.
Good morning, or good evening, wherever you're logging in from. It's morning here in Tucson, early morning. I'd like to thank the conference organizers for giving us the opportunity to share today. A little bit about myself. I'm a city planner by training, fresh out of graduate school in the 90s. I worked in Kansas, Arizona, and New Jersey. And in those roles, I learned a lot about process-based community planning approaches and systems thinking, which we're going to be speaking about today in the local and regional contexts. Later, I worked for the U.S. Department of Housing and Urban Development for the U.S.-Mexico border for a range of communities that lacked infrastructure. And I also co-authored 2 books about development issues in that context with the academic press. In this panel, I'm drawing upon my evaluation experience as a social scientist and a program evaluation consultant. And I've worked the last 5 years with Dr. Mary Adam supporting public health work in Kenya as well. So we're going to talk a little bit to start about the Human Capital Index and what it does. And so we see this as a powerful measurement tool that works well in complex systems by pulling together the cumulative impacts as shown here of health, education, and economics to measure human potential. It quantifies the contribution of health and education to the next generation of workers. And it's not designed, though, to function optimally as one zooms down to the local level where implementation occurs, which is what we'll be talking about today. There's 5 indicators that are captured in the index, and we have them listed here. They're relating to child survival, school enrollment, quality of learning, healthy growth, and adult survival. And those are captured in the index itself. As you zoom down to the local implementation level, though, there's multiple complex interactions between different health, education, and economic sector programs. So even though we see it as a potential measurement tool, it's not a key to unlock potential. The slide we have here talks a little bit about how human-centered design can do that. But before we get into human-centered design, we want to define our terms and explain what exactly we're talking about. So on this slide, as you can see, to borrow from Stanford's definition, which has pioneered a lot of the tools and thinking in the field, human-centered design is about building empathy and understanding of the human need and experience to guide the innovation process and the solutions that have proven challenging to implement. So it's very much focused on implementation. And in doing so, it can unlock human potential. And we emphasize, and we'll talk in depth today in cases, about the 3 elements that make up human-centered design. Starting with the inspiration phase here in blue, empathizing and defining the problem, ideation, which is the second phase of generating ideas, co-designing and prototypes, gathering feedback, and then finally implementation, where we're testing, planning, and iterating, and then continuing this cycle. So what we'll be talking about today is how human-centered design is a key that unlocks human potential captured in the index. And it's uniquely suited to do so in complex systems, and we'll talk about that in 7 different ways. We've listed them here, but I want to mention them because they're all very important, and you'll hear this in the speaker themes today. So human-centered design is very good for driving engagement, for working with multiple stakeholders, redistributing power dynamics. So we'll talk a bit about how that works in case studies. Human-centered design is also good for facilitating iterative problem solving as things rapidly change in different environments. It's good for measuring divergent outcomes, for creating new measurement approaches for process change. And then we'll finally talk about how it can be well suited to build trust. And in so doing, that can leapfrog systems barriers. We want to emphasize, as you hear these themes today, with the range and scope that human-centered design has, it can be a very critical catalyst and a measurement tool to achieve the Sustainable Development Goals and accelerate positive change in the Human Capital Index. And with that, I'd like to turn it back over to Mary.
Thanks, Angie. Well, the Human Capital Index, developed by the World Bank, is a great measure of human potential. And I want to use that to point us back to our global audience, okay? Because we're focusing on human-centered design and how it links to the Human Capital Index. And I have put up a poll, and so I'd like to point you to the live poll and address the question, have you used or participated in human-centered design in a professional capacity before? And if yes is your answer, could you share some about your experience in our discussion forum? Now I want to introduce a series of speakers who have had a very extensive experience with human-centered design, and they've used it in multiple different types of contexts. I want to start with Cora Nally, who is coming to our session from the Bahamas. Cora, can you tell us a little about yourself?
Sure. Thank you, Mary. Hello, everyone, and thank you for joining us today. I'm honored to be sharing this time with you and with the 4 other accomplished women on the panel with me. I'm coming to you today from the Bahamas, where I have been working the past year on the Hurricane Dorian response. I began my career in public health as a Peace Corps volunteer in Benin and have been fortunate since then to live and work in 11 countries on 4 continents, building healthy communities with strong systems, programs, and partnerships. I'm currently pursuing a PhD in health systems from Ghent University in Belgium. For the purposes of this panel, I will be focusing on my experience developing a community health worker program in Sierra Leone at the height of the Ebola epidemic. There is a quote in the Black Book of Proverbs, a compilation of proverbs from the entire continent of Africa, that says, if everyone helps to hold up the sky, then one person does not become tired. I think this reflects the core principle of human-centered design, which encourages us to solve problems and build solutions by including many people and perspectives in the process. This was certainly helpful for me when I built a community health worker force in Sierra Leone from scratch during the Ebola epidemic. I had been hired by Partners in Health to fly to Sierra Leone and work with a group of 36 community health workers who I had previously trained to support maternal and child health in their villages near Kono in northern Sierra Leone. When I landed at the airport, I was instead sent to Port Loko, the epicenter of the Ebola epidemic, and told to hire and train as many community health workers as I could as quickly as possible. The human-centered design process starts with people you're designing for and ends with new solutions that are tailor-made to suit their needs. And this process was extremely helpful in building a program from scratch. The first stage involves assessment. This is the part of the process where you ask a lot of questions and listen very carefully. It's best to begin this process as well with no assumptions on your part, because you really want the context and the people involved in the context to inform what you do in your next steps. So here is where we ask who we're hoping to benefit, what's happening. We identify gaps. We also try to figure out what filled those gaps pre-event and why that system is no longer working. So in the context of Sierra Leone, this involved, like I said, asking a lot of questions and listening a lot before moving on to the next phase. So the next part of the process involves a lot of sticky notes, and there are no bad ideas or suggestions. This is where my team and myself took everything we learned during the assessment phase and laid it all out as much as we could. We thought about what programs or activities could fill the gaps that we had identified. We thought about what systems might be needed and what resources would be needed as well. So for example, in the Sierra Leone context, the health system had completely collapsed and healthcare was only being provided in the silo of the Ebola treatment facility. But the facility itself was not connected in any way to the community or to what was happening in the communities with Ebola at that time. So we needed to develop a system to bring the community, the people impacted by the epidemic, and the health system, the Ebola treatment facility, together and build a structure around those. So the brainstorming time, again, like I said, there are no bad ideas. This is where you throw everything on the wall, literally, in the form of sticky notes. It's a very tactile way of processing the information that you learned in the assessment phase. And then this leads you to the next phase. So here is where you design a system. So you take all those sticky notes and you try to make sense out of them. You start by grouping them in ways that they're similar to each other. And then eventually, as you move through this process, you will see a system begin to develop. You can see the image on the slide. There are some of our pink sticky notes there from the brainstorming phase. And the green rectangles are the system or the process that was being used at the Ebola treatment facility for people presenting with symptoms. And there are pink stickies. Those are all the ways that the program we are building are going to directly impact and develop a system around what's already happening at the Ebola treatment facility. This is how we're going to bring the community and the facility together. This is the exciting part. This is where you get to dream big and build, design a structure. It's very important that as you're designing too, you'll be sure to include feedback loops. You have to have an adaptable program model to accommodate the fluid nature of a response or of any program. You really need an adaptive program, even if there isn't an epidemic or a disaster. But it's especially helpful in those contexts. And now create and integrate. This is where you build the model. So this is where we built our program. We hired and trained 680 community health workers, and they were ready to begin working within 5 weeks of me landing in Sierra Leone. The program was adaptive. Stakeholders were involved at all levels. Next slide, please, Angie. So here is what we ended up creating from using our human-centered design process. We developed 3 cadres of community health workers, field-based. So they were responsible for delivering evidence-based information in the community, and they were active case finders as well, looking for sick people. We also developed facility-based community health workers. These were survivors of Ebola who provided direct psychosocial support in the Ebola treatment facility to the patients that were there. This was especially crucial for children who were in the Ebola treatment facility who were unaccompanied by other family members. They also provided an important communication link back to the communities and the families that had been left behind and were now in quarantine. Our third group was psychosocial support community health workers, and they maintained quarantine integrity, providing for the families that were in quarantine while their loved ones were in the Ebola treatment facility. And they also helped reintegrate survivors into the community when they returned home. As I said before, we did design continuous learning systems and feedback loops into the program. So daily, we took external information from the other NGOs working, the government of Sierra Leone, the British military, which was in charge of the response, as well as internal information. We spoke with our community health workers and our supervisors daily, and any information that we learned, we used to adapt the program, either changing the health messaging, changing where we were focusing our resources, always trying to stay on top of the ever-changing context of the epidemic. So this is why it worked, in my opinion, is because we had the trust of the community based on the fact that we hired community members and they worked in their own community. And this trust helped us to instantly develop a system that was impactful. And this particular design is going to be spoken of later. This is something developed by Mary and Angie, Reciprocity towards a trusting relationship. Next slide, please. And so this is where the components of this particular program intersected with this model, and I believe lent to the strength and success of the community health worker program in Sierra Leone. Thank you very much for your time.
about some of the work that you did in Sierra Leone during that Ebola epidemic. And I know you're continuing to work with disaster response issues in the Bahamas. I want to introduce our next speaker, and as I'm asking Brooke to unmute and prepare to start talking, I want to remind you to answer the poll. We are interested in finding out if you have had professional experience using human-centered design. So I'm going to hand it over to Brooke. Tell us a little more about yourself.
Thank you, Dr. Adam. I am honored to be here. Again, my name is Brooke Shelton, and I'm joining today from Arizona. I am currently pursuing my master's in public health at Johns Hopkins University, and I'm also a senior consultant for patient experience with a large healthcare system here in the southwestern US. So about 7 years ago, I started incorporating human-centered design and participatory models when I launched my own business to support nonprofits, K-12 schools, universities, and public library systems, as I was supporting them with leadership development and some collaborative implementations. And what I learned through that is that people and teams often have just a surface level understanding of how to collaborate to reach, whether it's reaching certain performance metrics or implementing a new initiative or program. And groups with varying levels of power dynamics, as you may know, may have an even more challenging time coming together to collaborate when they have different maybe objectives and self-interest when achieving a common goal. So if we could go to the next slide. I am excited to be here today to share a little bit about how I was able to use a human-centered design framework and apply it in more bite-sized chunks to alter power dynamics, to drive engagement, and to catalyze problem solving in an academic hospital here in the US. And so I'm excited to share too that you don't need to embark on this long, arduous process. You can start applying human-centered design in small ways to your existing work. So most recently, I've been applying human-centered design tools and strategies in this large academic medical facility. And as I mentioned, I lead patient experience initiatives, which, like many other initiatives in a health system, the problem solving and decision making often happens at the top or in departmental silos. And from my experience with human-centered design, I was curious to see if some of the tools would translate as we create and implement patient experience solutions in this medical facility. So as you can see here on the screen, I was focused on how can we boost engagement, how could we foster greater empathy, how could we use some more creative primary research to better understand the needs within the hospital with patients and staff, and then also how could we engage in iterative problem solving, ideation, and experimentation. So if we move to the next slide, I'll share just my first story, which is about the emergency department in this hospital. And so this department was really facing a challenge with underperforming in its patient experience overall and was receiving real low scores in patient experience. And this was due in part to just some division and the lack of trust, both horizontally and vertically in the department. And so we saw an opportunity to bring together a cross-departmental team, which included nurses, physicians, residents, billing and administrative staff, and a social worker. And in bringing together this group, the first step we took really involved a great deal of empathy. And as you know, as Angie shared in an earlier slide, empathy is woven throughout the HCD process, but we often only think of empathy, of building empathy for the end user. But I want to stress the importance of really building empathy among the team members who might be working on the solution or initiative. So with this group, we used a tool, it's a life map, where the team members mapped out their life experiences from birth to today that may have contributed to them working in the emergency department. And this really was a foundational way to build respect and trust among team members who maybe they've been working in the same department for 15 plus years, but they had never really known much about that person outside of work. And we saw this as a crucial piece to beginning to trust one another so that they felt like they could work together to start developing some solutions and better understanding the problem. And so speaking of the problem, that was the next piece that we really focused on was further defining the problem. And as Cora shared in her presentation, we don't want to enter into the human-centered design process with too many assumptions. We can start with some assumptions, but we really need to go out and talk to folks who are greatly involved with the problem to better understand it. So we did a listening tour in the department and some staff interviews, which may seem so simple, but it's a step that we often forget, is to take the time to listen to others. And so following that, and so we're able to further define the problems in the department as to why the patient experience was suffering, we came together again as a group and did a lot of ideation. So similar to Cora, we used a lot of sticky notes, and I'm a big proponent of the sticky note. It's a really inexpensive way to do a lot of things, to generate a lot of ideas, but also to create some equality, to allow more voices to be heard. So if you're one of those people in meetings like myself who might have a lot of ideas to share, we want to make sure that others at the table have a voice. And so the sticky note is a great way to do that in the ideation phase. And so you'll see even the sticky note on the slide here. And then the last piece I want to share with this group, what we did is we broke into sub-teams to then actually create some potential solutions and test those. And so each month we came back together to share how did the solution work, and then to pivot or to iterate on that solution. And so the outcomes that we saw, we were able to implement a lot of new communication processes. The group realized that hospital administration had not been included in the daily huddle that they had, and so they started including them so that they had a better understanding of the hospital capacity and could make some improvements with regards to throughput. And ultimately, this group really saw greater trust and collaboration then across these kind of key teams. And this ultimately resulted in a 30% increase in patient experience scores throughout the year. Now, I want to mention that this was a small team of about 12 people, and this department was quite big, with around 200 plus staff. So we knew there was a greater level of engagement that was needed to really see a shift in this patient experience initiative. So if we go to the next slide, the piece that we moved to next was to host a data party, which is kind of what it sounds like, a party. We had food, we had music, and most importantly, we had data. So we took the patient experience data and brought together these 200 plus team members across a couple of different meetings and engaged, again, staff in these multi-stakeholder or interdisciplinary teams. And this was groups of bedside nurses, techs, physicians, and leaders who, I should mention that many of the people who were part of these teams maybe never had exposure to this patient experience data before. So this was really critical, knowing that many of the staff were kind of disengaged and weren't taking ownership of the patient experience. And giving them an opportunity to see this data really was kind of creating a shift in the department and starting to maybe redistribute some levels of power. So these multi-stakeholder teams, similar to what I just shared earlier, we started focusing first on how can we build empathy with one another. And so they shared some of their personal experiences and stories, and then jumped into collectively analyzing the patient experience data and ultimately doing some rapid sticky note ideation to develop some solutions. So one of the teams in reviewing patient comments really noticed that, wow, we have a lot of patients who are saying that they've been real frustrated waiting in the lobby. They haven't felt acknowledged when they first come into the emergency department. And so as a group, the staff decided that they would create this rounding rotation where a staff member would come out into the lobby and welcome patients, acknowledge them, and provide updates with regards to wait times and next steps. So this was something that, quite simple, but if just, the director of the department would have asked this, staff to roll out this type of initiative, I don't think it would have seen as much success had it not kind of come from this human-centered design process that we were able to use in the data party. So I want to share just one more story. If we could go to the next slide. I was also able to work with a group around this quality improvement initiative known as ICOF, which the hospital was rolling out to reduce the likelihood of post-operative pulmonary complications. And when I started working with this group, the challenge here was that when the initiative was rolled out, everyone was, really excited about it, which we know is often how things start in the beginning. But over time, sustainability seemed a bit bleak, and so we knew there needed to be a greater level of buy-in across different clinicians and teams. And so what we ended up doing was, again, bringing together cross-functional teams, which maybe I sound like a broken record now, but there is a theme here. So making sure that we brought together a mixture of nurses and techs, managers, physicians to work on small teams. And this was just for one meeting that we had to do something known as an empathy map. So if you're not familiar with empathy maps, they are a common human-centered design tool that asks questions about a specific stakeholder group regarding their thoughts and feelings, their hopes and fears, and maybe what their daily environment looks like. And empathy maps are really useful for kind of broadening our perspectives and for walking in the shoes of another individual or another group. And so we had these teams complete empathy maps for patients, for patient families, for techs, nurses, residents, so that they could kind of, get inside of the mind of those other individuals and maybe start to see what might be some of the barriers to compliance with this type of initiative. So just to share too, we had kind of a breakthrough in this when they were completing the empathy maps around nurses. It was kind of discovered that one of the med-surg units, the nurses there were short-staffed, and so it was a challenge to ensure that patients were having their teeth brushed or had an opportunity to brush their teeth, which was a key piece in this ICOF initiative. And so the respiratory tech team, who happened to have representation in this group, were able to step in and say that's something that we can help with. We have the capacity to do. So this just showed that how using something like an empathy map, which is quite simple, can start to build some bridges across different individuals and teams to ensure that the initiative could be more successful. So I want to wrap up by just sharing that, yes, you may have heard about human-centered design as a framework for launching new ventures and innovations, but the principles and strategies can be applied to already existing teams or initiatives and programs. You don't need to be launching fancy tech solutions. Human-centered design can help generate greater trusting relationships and collaborations that lead to even the simplest of solutions, which can make a big impact on your organization or community. So I will hand it back to Dr. Adam.
Thank you so much, Brooke. It's really been fascinating to hear about human-centered design and the way it's been implemented, first under a crisis situation, the Ebola epidemic in Sierra Leone, and second, in a highly established health system in Arizona. And now we're going to hear about it from a third perspective. I'm welcoming Dr. Lydia Okutoi from Nairobi, where she is the Director of Quality at Kenyatta National Hospital, and talk about big. This is a 2,000-bed facility. And so Lydia, tell us a little more about yourself and about your work and design experience.
Thank you very much, Mary. A pleasure for me to be on this forum and to be with this great team. My name is Lydia, as Mary has said, and I work at Kenyatta National Hospital. I support the Quality Healthcare Directorate. So my journey as a clinician started a while ago, but midway I changed from supporting the patients directly, offering the adrenaline-loaded obstetric services, but now to support the system. So it was like taking a fish out of the water. And very soon I discovered you need to learn to engage and to hear. And indeed, human-centered design has become something that we leverage on, an approach that we use at the hospital. So I now support the hospital on matters, process improvement, patient safety, and amongst others, and IPC now with matters COVID, with the COVID pandemic. So IPC becomes very important. And so engaging across horizontally across the system and not the vertical usual way, because the people we talk to, it's not necessarily that they report to us, but we give them skills, we help them solve problems, we investigate incidents. And so human-centered design became an approach that we needed to optimize, and we continue to learn. So I'll share a little bit of experience on how we've done it at Kenyatta. Next slide. Next. Okay, thank you. So just to reiterate what the other speakers have said, indeed this becomes a very important aspect of our problem solving, because it is pragmatic. It helps us approach the problem with the stakeholders in the center, in that we're trying to listen to the patient, you're trying to listen to the staff. And here we derive inspiration from solving a problem that is dear to the people at the front line, and supporting their good outcomes, what they desire to happen differently. And together we are able to ideate and get solutions, or even see what we can approach management for support in case it's beyond our realm, and also conduct implementation and go back to where we were, like a cycle. And so this gives us extra skills for I, who's used to quality improvement routinely. So this brings in the middle matters of involving people who will continue with this process even after the project is over. So the human-centered design brings richness in our quality improvement, that it helps us identify what is relevant, what is culturally relevant and sustainable. Those who've been in the facilities, you know that even within a hospital, all the different cadres have their own approaches, their own way of doing things. Doctors are a different tribe, and nurses are a different tribe. That is with what? Because they all think in a different way. So you're able to get these stakeholders, from the biomedical engineers to the clinicians, be able to have ideas and change initiatives that are going to be sustained because they were involved and engaged. And so this brings it more functional, breaking the hierarchical structures that commonly exist, and then also considering the human factors when designing interventions for this context. Because whenever there's a problem, you are called to look for a solution. But human-centered design brings that person nearest to that problem in the center of the discussion. You'll not just design for them, but they will be part of it, and you will think together and implement together. Next. Yeah, this is an example of a QA project we had. Our aim was to reduce the admission of term babies to our newborn unit at Kenyatta National Hospital. Our newborn unit is fairly congested. Most of the time, we may have more than 100% bed occupancy. And so identifying that our labor ward in the hospital was one of the major contributors to the admission, and some of the babies who are going there were going for care events that could have been avoided. For example, just a poor score leading to a child having breathing issues and needing support. So this became something that is needed for the sake of reducing admissions and reducing the number of the workload for the nurses, and just reducing infection prevention and control incidents within the newborn unit by avoiding this overcrowding. So we engaged the labor ward staff. We had a brainstorming moment that pictures one of the brainstorming moments, and they were able to think through that we've been following the mother most of the time, but now we want to ensure that the baby is okay. That means that the mother will even be given better care to make sure that there's proper intrapartum care, use of the patograph, proper hand hygiene during the vaginal evaluations, and even being able to receive the baby well. And so the project focused on some changes and appraised the rest of the team. And this meant that they would increase use of patograph, would have training for newborn resuscitation, and residents being available to receive the babies, because we used to have them being received just by the nurses. So now we had somebody who was a little bit more senior to resuscitate a baby who needs more support. And this project, at the end of which, led to reduction of the admission from 11% to 1%, that is for the term babies, and 16% to 6% for those who were born by cesarean section. So it was a great improvement, and currently some of the aspects are still being maintained, and we hope to go and reevaluate where we are. Next. Another important team that we have learned to engage is the nursing. By profession, I am a doctor, so at times reaching to the nursing team looks like you're talking at them. But now those power dynamics differences, we needed to have them know that they are part of the team and that we are going to engage them for the purpose of ensuring that healthcare quality, the division that I lead, is able to support them. And they interact with the patient. More than 75% of patient contacts are by the nursing, especially the inpatients. And so when we meaningfully engage nursing, they are leveraged, they are an Achilles heel for us to succeed at the front line, because they are the advocates for the patient. And we had a few projects. One of them was addressing the low vital sign monitoring during routine audits. And when we reached out to them following some of the audits, they were able to identify that there's much they can do, and that within themselves, they even have different various performance. They could have benchmarking to increase the number of times that the patients get their vital signs taken, especially the long-term patients. And so we listened to them. They were able to say they are few in number. At times the BP machines are not available, and documentation not being standardized. And for this, we were able to have the other stakeholders, from supply chain, from biomedical engineers, and even just ensuring that they're able to order, because some of the items were available, but for some reason they were not being ordered. So we're able to have this as part of their internal benchmark within their own division. And this has greatly increased the number of times that vital signs are taken. The first target, we scored 100% in ensuring that there's one entry for vital signs for the chronic patients who've been there for a long time, because some would go with no official documentation for a whole day. And that is especially the people who've been in the ward for a long time. The emergency patients, the acute ones, they used to be a little bit better. And so the hospital initially was not happy that would take such a mundane improvement initiative. They're like, no, it doesn't happen. But we confirm to them that it happens, and the nursing division are willing to do something about it. And so the human-centered design means that the truth that is happening on the other side, you're able to empathize and together to agree on what are you going to do. Currently, we have this as part of their performance contract for the nursing division. And so it is cascaded through the whole hospital. And now when we come to COVID era, this becomes an important aspect of ensuring that all vitals are taken, because we need to have routine oxygen saturation being monitored even in the general wards. And so they got a fertile ground that there was already an initiative supporting vital signs. And so the oxygen saturation becomes just part of what is being done. And it is a great success. We are hoping that we'll have more supply even for the items needed to look at matters oxygenation, because the breakdown for the pulse oximeter is fairly high, and we are able to discuss it. Next. So to end my presentation is just to show how we have engaged nursing with some pictures. This year's World Patient Safety Day, we celebrated it on 17th, joining the rest of the globe, and the emphasis was health worker safety. And this being the year of the nurse, we further went ahead to engage them by having a cake. The healthcare quality division made a cake for nursing and asked for the leadership plus the union leadership, because having a COVID pandemic happening currently means that matters, PPEs, and people wanting to not to come to work means that union is right in the middle of supporting the quality of PPEs and agitating for nurses to get a better care and treatment during COVID. And so we called them and had a roundtable discussion just to find out from where they sit, how they want us as healthcare quality division to support them. What can we talk to at the level of the board? What aspects would they want us to support in terms of quality improvement to get metrics around them and to have it being measured in a systematic way. So that is the end of my presentation with the lovely pictures from our World Patient Safety Day when we emphasized on engaging the nurses. Thank you. Back to Mary.
Lydia, it's been fascinating to hear the different ways you've used human-centered design. And I particularly appreciate the moment of celebration you shared, because applauding our colleagues and their successes is an important part of relationship building. Now, I do want to point to the poll, and I am attempting to share results. And it's interesting to know that among our participants, the vast majority have never used human-centered design. And those who have used it reported using it in contexts like developing health communications and other participatory kinds of processes. So I think for our audience, it's been really helpful to be able to look at the different types of ways you can use human-centered design in one's daily work, whether it's a disaster, existing teams, or addressing long-standing quality improvement issues within a hospital system. I want to turn it over to Angie now to talk a little more about the ways that we can build, because human-centered design is particularly valuable for implementation science. It can really help us bridge that no-do gap. And it does that because it can facilitate stakeholder engagement, it can grow empathy, and help with understanding both our stakeholders or our patients. It can facilitate problem solving, and it can create a place to find alignment, even in settings like Kenyatta National Hospital, where you're dealing with power dynamics and issues related to a unionized workforce under a time of COVID stress. So Angie, I'd like you to talk about human-centered design, particularly in its relationship to behavioral theories. I'm handing it over to you.
Thank you, Mary. I want to share just a couple slides of a little bit more about human-centered design and its utility. One of the things that Dr. Mary Adam and I have been working on the last 5 years in the context of Kenya is trying to understand how theories of behavior change need to be linked to human-centered design. And this was one of the things that was actually in the discussion chat. One of the participants brought this up. Sometimes using human-centered design is a great tool, but without theories of behavior change, it's hard to really catapult its utility beyond just use as a set of methods and problem-solving skill sets to really changing behavior. So what we've tried to do in the last 5 years is understand what kind of theories are relevant for that. We just want to also emphasize we have a paper in this conference session for this conference. In health systems research, there's a special implementation issue that just came out. Dr. Marianne Adam and I, along with her health team, published a paper that came out about the work we've been doing. And also there's a podcast that came out as well, along with the implementation issue that features us and 2 other people who are using implementation research in the context of their work. So just want to emphasize that and point that to you as a resource. So in the understanding and trying to understand this gap between information and understanding behavior change is what we're trying to use theories of behavior change for. What we came upon is a theory of trust building that we developed, building upon the literature. And we see that as trust is really an essential issue for the whole spectrum of implementation science. We want to point out here that we've cited Lucy Gilson, who talks a lot about this, with trust being the pivot point. And it's a pivot point in between behaviors, in between people and people, in between people and organizations, and in between people and events. So in so doing, we see trust building is really central to health systems. And so what we want to do is present our theory of trust building for behavior change, which Cora demonstrated in her presentation, and just talk a little bit more about that, how we need trust in the health system, since trust is so essential for lubricating the health system, making it more efficient, making it more effective. Cultivating trust also being important because it contributes to one's access to care, utilization and adherence of evidence-based recommendations, and thus improving outcomes. But because trust is not a given, we wanted to understand what elements are really critical in a theory of change to link to understanding that and using it in the human-centered design context. So how do we bridge the gap? And in a lot of the literature, some people seem to think of trust as sort of a leap of faith, this optimistic acceptance that someone is acting in your best interest is how someone had defined it in the health literature. But what we wanted to do is try to understand it in smaller pieces. So we came upon in the literature this idea of reciprocity. So reciprocity being a building block or really a precedent of trust. So we borrow from the behavioral psychology and the economics literature, which talks a lot about this idea of reciprocity being a more narrow and a bounded concept than trust itself. So you can think of it as reciprocity as the ability to repay a favor. And if you can generate reciprocity, the theory here is that you can create a process to build trust. So we focus on 3 building blocks, which we've shown here on the slide. And I want to talk about the reason that we think this is important, because it can show your organization or your partnership where you might be missing these elements and diagnose how you might build it, how you might better build trust as you're working in multi-stakeholder partnerships. So the top of the graphic you can see is yellow here for self-interest. You can think of self-interest as your motivations or the goals that you have for participating in a partnership, or that anyone who comes to a partnership might be interested in participating. So the kind of questions you can ask when you look at this yellow box are, how are you able to identify and fulfill your interests? How does participating in a larger group help you meet those interests? And those interests can be intrinsic, such as fulfillment of self-worth or belonging, and they can also be extrinsic. So, for example, for improved reputation or tangible benefits like employment. And it's important to recognize that self-interest should be identified at multiple levels in a health system, but that they can also change over time as a partnership evolves. On the next slide, you see common goals in this blue box here on the slide. And the questions here that are relevant are, what are the shared or common goals within your partnership? The intersection of where individuals bring their own goals to the partnership. What is the intersection of the common goal here? And as you work on achieving those goals, how well do you share power, responsibility, and authority among those who participate? And in so doing, distribute leadership. And then on the right side here is gratitude and indebtedness. This is essential and really critical and emphasized in much of the literature. Do stakeholders thank each other? Do they thank their networks? Do they publicly acknowledge others in some sort of way? And so here's how the three pieces work together. When your self-interest is met by another, they did you a favor or they fulfilled some kind of need, you have a desire to respond in kind. And this is found in evidence-based literature in psychology, something called equity theory, which we have a natural tendency to right-size our relationships and reduce perceived inequity. And on the other side of the coin is gratitude. If someone meets your self-interest and does you a favor or says thank you, you acknowledge the gift and you express appreciation, and they're more likely to do it again. And gratitude has been shown in helping relationships grow. Researchers in relationship marketing really understand this because it's shown in the literature that it makes clients more likely to come back to them just by thanking them alone. So gratitude is a future mediator of trust. And as relationships grow, partners come closer to achieving a common goal. And in doing so with power, responsibility, and shared authority, they can give those lower, traditionally in a power ladder, to have more authority in their lives and more decision-making, as we've talked about in the human-centered design context. So trust can assist in navigating thorny implementation problems that often derail evidence-based interventions. And therefore, a theory of trust building we see for behavior change really can leverage impact. And as we mentioned, we've applied human-centered design to enhance engagement and problem solving, and we linked human-centered design to a theory of trust building, Dr. Mary and I in Kenya with her health team, to drive an engine of change. So how does that influence thinking, behaviors, and outcomes over time? We'll talk a little bit about that and have a slide with where you can access those resources well at the end of the presentation. So with that, I want to turn it back over to Dr. Adam.
Angie, thank you so much for talking about ways that human-centered design linked to theories of behavior change, specifically this theory of trust building. And I've put up a new poll, and I'd love to have our participants take a look. And poll question is, have you found trust is directly linked to success in your professional experience? So take a moment and answer questions in the chat, in the poll. And if you found that it's been helpful, then share a little more about that in our discussion forum. So Angie, how did we move on and really link human-centered design to theory?
Thank you, Dr. Adam. What we did, how did we link human-centered design to theory? So the way we conceptualize this engagement is really in visuals, and that goes along with a lot of the human-centered design techniques as well, trying to capture things in visual elements, whether that's with sticky notes, but also in terms of processes. And so what we did is we tried to conceive it as individuals rolling a trust up a hill, essentially, with the three components, which you can't really read too well, but self-interest, gratitude, and common goal represented as pieces of the cycle in those balls. And so the ideas here were recognizing and meeting self-interest, identifying intersections and achieving common goals, and showing gratitude in each iterative cycle. So the three parts of the cycle also address, as Brooke discussed, the ability to build empathy for those participating. And so trust building really intersects well with human-centered design because it captures these ideas of empathy that are so essential in both trust in terms of a theory, but also human-centered design as a process. And so in our paper, we discuss this a bit, and we show how human-centered design helps community health volunteers have a process to stimulate understanding of their assets, to develop a common goal for a healthier future, and then to jumpstart reciprocity cycles for trust building and community transformation. And also thinking about how those three elements can help diagnose where they can do a better job of creating empathy and jump-starting their work. I'm going to turn it back over now to Mary.
Thank you, Angie. So I am attempting to share the results of the poll, but about 80% of people said they found trust was important in their professional work success. And I think the ability to link human-centered design to trust is a really valuable thing. Next slide, Angie. So I want to talk a little bit about ways human-centered design addresses some of the thorny problems that we are working with in implementation science. And any good implementation requires substantive stakeholder engagement. That's something human-centered design helps support. Good implementation of any project requires deep understanding of the local context, so you know how to develop and adapt something. And I think it's worth looking at, how does this link to the human capital index? Because the human capital index is measuring things at this 50,000 foot macro level. And what we want to do is help you see that measurement on the ground, that implementation science piece where you are helping do a better job of actually delivering evidence-based interventions, ones that will support child survival and nutrition, things that will drive better school enrollment, things that will support quality improvement in the health system, okay? Things that will address our chronic care problems. As we see momentum sustained and better local adaptation of the evidence-based interventions, we're going to be able to detect that in aggregate level at the human capital index. And I think that's what we saw. We saw that in the work presented by our experts. Brooke showed how empathy and deeper understanding drove really diverse teams to improve patient experience. Lydia talked about how letting user-generated, nurse-generated ideas improved issues in their newborn unit from 11% to only a 1% readmission rate. And Cora showed, in addition to how essential stakeholder engagement was during the Ebola time where things were very fearful, she showed how to leverage trust that people had in existing relationships to be able to drive health services support. So in summary, and can I have the last slide, please? I think human-centered design can add up to big gains in accelerating our movement towards developing and accessing full potential that's measured at the Human Capital Index. It helps implement effective interventions, those things that will support the ultimate improvement in potential. And implementation science toolkits can use human-centered design to drive progress on the ground. And linked to theory, they can catalyze program effectiveness. So at this time, I'd like to ask everyone in our participating audience, this is a time to go to the live Q&A and write in your views on or your questions for the panel. And Angie, thank you for putting up the slide that shows where there are additional resources. The website Trust for Change is available so that we can help share more of the resources, including the paper that was part of the implementation science launch in health policy and planning. So with that, I want to ask all of our panelists to come forward, and I'm going to start with some questions. And I'm going to direct my first question to Dr. Lydia Okatoy. Lydia, what do you think are aspects of human-centered design that are most attractive to decision makers? Lydia, if you can unmute and share your video.
Thank you, Mary. Yeah, I think for decision makers, the aspect that having human-centered design in engaging on in initiating a project or looking at its progress, the most attractive aspect of it is the fact that you will inspire innovation through your engagement. So they're coming in wholeheartedly because you are putting them at the center. So if I know that I will gain the most from it, that is important. But on the other side, decision makers are now more than ever being asked to have either community participation, people engagement. So human-centered design makes this a natural way of ticking that box while seeing the utility of the same. That if I'm engaging, involving, and having brainstorming sessions that ensure that the stakeholders are the ones who are bringing what matters to them on the table, what is valuable to them, then there's a higher chance of it succeeding and a higher chance of it having sustainability. And of course, it means that if there's resistance, it's likely that it will be minimal, or they'll be able to be very balanced about it. And the decision makers would want their capital, that is the human capital that comes every day to work and go back, to bring all their assets when they come to work. So human-centered design just optimizes what they can deliver, and any decision maker will be happy for that to be the case. Thank you, Mary.
So, Brooke, you also work in an extremely large health system. I'd like to ask you to unmute and say what you think the aspects of human-centered design that are most attractive to decision makers upstream in your hierarchy are.
Sure, thank you, Dr. Adams. So I would say that one aspect that's incredibly useful with the human-centered design process is the ability to quickly receive feedback. So I know even as Cora mentioned in her presentation, the feedback loops, that's something that at least I saw too in the academic medical facility that I've worked in, was to be able to hear from those at varying levels. How was the solution working as it was being implemented? When we come back together as a multi-stakeholder team, that we can share that feedback quickly and then iterate and adapt our solutions based on what we're finding. I would also say too, just the element of building relationships across varying groups of stakeholders. It's pretty impressive how human-centered design, when we're looking at it through the lens of trust building, can really foster relationships that maybe some decision makers and folks in different levels within an organization didn't previously have. And we know that when we have those strong relationships, we have greater trust, and therefore we can sustain some of our improvements over the long haul.
Thanks, Brooke. I want to address the next question to Cora. How did you adjust to the realities of the power structures in your context? There's no question that community health workers are at the lowest end of the health system hierarchy. And how did that influence your use of human-centered design? Cora, can you unmute and share?
Sure. Thank you, Mary. Yeah, I think by what you mean about community health workers being at the, your explanation of them as part of the health system, I think part of that has to do with their impact and their role not being fully understood or recognized by all the partners in the health system. Community health workers, many studies have shown, give us the biggest bang for our buck in any health system. And they can save anywhere from, so for example, for every $1 spent on community health workers, there are studies that have shown that they save $7 in the health system itself. So they have a huge impact, but I think they're undervalued. I would agree with that. So I have addressed this by continuing to keep stakeholders involved at all stages of planning and also implementation. It's wonderful at the end of a program to be able to share, for example, that your 14 community health workers on a tiny island in the Bahamas have shared 120,000 messages on COVID in the past 6 months. That shocks people, but it demonstrates the huge impact that they can have on the health system and how they can help boost health messages. And again, how these messages will then come from a trusted and reliable source and be more likely to be taken on and taken up by the community that they're working with.
Well, with that, Cora, thank you very much. Our time is just about at an end. I want to thank all of our presenters, Dr. Okatoy in Nairobi, Dr. Donaldson at the US-Mexico border, Brooke Shelton also in Arizona, and Cora Nally in the Bahamas, particularly our presenters for whom it is the middle of the night. Thank you. And I want to thank all of our participants. I hope this has given you some great ideas and that you will be encouraged that you can move forward and institute human-centered design possibilities within the context where you work every day. Thank you so much, everyone. And with that, I'll close our session. Please contact us on email or through the website. Thank you.